It's good to be here. I'm Kate Adkins. I am going to talk today about eating disorders. I am currently, I'm a marriage and family therapist and supervisor and the clinical professional counselor supervisor. I'm in private practice, but I've worked extensively in eating disorder treatment facilities, outpatient, IOP, and partial hospitalization, and a lot of collaboration. And that is what I'm going to be sharing with you today. Let me go ahead and share my screen to get us started. All right, so today I'm talking about eating disorders in adolescence, and specifically the types of treatment for anorexia that requires a great deal of different systems to be involved in care. I'm not going to spend a lot of time on diagnostics due to time limitations, but there are updated changes to DSM-5. So I'm going to be speaking a lot to the anorexia component today because family needs is necessarily involved in refeeding in a very different way than with our teens with binge eating disorder. So what's so compelling about eating disorders is the medical complications associated with symptoms and that worsen psychiatrically when the brain is malnourished. Though most disorders fall on a continuum of disordered eating to eating behaviors under control to over control, the most severe and life-threatening are the restrictive eating and the binge purge behaviors where there's weight loss and significant effect to different medical systems that you can see here, kind of a blurry chart. So there is a trend I want to note towards something called orthorexia that is not medically recognized as a separate diagnosis, but it is this idea so restrictive eating disorder with a denial of a body image related component or trigger. So this is kind of this healthy eating idea. It's really mostly about what I put into my body, limiting certain types of food. Very similar to anorexia, there's just often that denial of a body image component or fear of weight gain or being overweight or fat. And so this is something I tend to notice that clients feel more comfortable using to identify than anorexia, though treatment is the same and symptoms are the same as well. I'm going to talk a lot about restrictive eating today, and I treat in general anxiety disorders. I do a great deal of exposure therapy for OCD, phobias, as well as trauma therapy. And what I'm going to share about refeeding with restrictive eating is very similar to exposure therapy. Likewise, the obsessions, compulsions, of even avoidance compulsions with restrictive eating, they just mirror OCD right on target with the type of treatments that we do and how difficult refeeding is. But with anorexia, with all these medical complications, there's a great deal of urgency to refeed, as well as significant distress. And when we treat OCD, often, when we move toward exposure, we are demonstrating that we can engage in the avoidance behavior, the compulsive or disobey, right, the OCD, without the negative consequence. But when we refeed, that individual actually does experience body changes and weight gain. But due to the extreme body dysmorphia involved, they're unaware to see that their body isn't really changing. They're reaching health and not overweight. So there's a lot of complexity. But keep in mind this idea of the OCD. It's very similar, and it helps explain the significant distress individuals are in when they are in the refeeding phase. So a lot of medical ties and difficulties. Most clients with restrictive eating are hospitalized for bradycardia and protein calorie malnutrition. There is significant risk for head injuries from passing out, falling. This happens often after sporting events and in the shower. A lot of other long-term effects of binge eating disorder, which I just really will not spend time going into here. But of course, like you probably see in other talks, there's hours of information on each of these. So anorexia or eating disorders in general are often underreported and unidentified. They're very serious. Number 2 cause of death from mental illness. It's a pretty high lifetime prevalence, and risk of death is very, very high as compared to other mental health struggles. So this is something that's really important to discuss, to know about. I find that a lot of clinicians aren't trained in their graduate programs on evidence-based treatments or specific training on eating disorders. It's kind of on-the-job learning and difficult. When I talk about anorexia today and the difficulties that families have with refeeding, it's helpful to remember that these are often, but not always, people-pleasing, perfectionistic kids whom parents have never had to parent in the way that's required. So there's a huge learning curve of the diagnosis, the type of treatment, all the medical pieces, as well as dealing with a child in significant distress where you have to have very firm boundaries and consequences. A lot of comorbidity you can see here. A lot of course, with OCD, PTSD, major depression, general anxiety, as well as substance use. So this is where it gets really compelling if you're not familiar with eating disorders. So Ansel Keys did an experiment in the 1940s on the biology of human starvation, where they took a group of medically and psychologically screened men to kind of replicate a significant weight loss and refeeding process. What we learned was that there is a great deal of associated of malnutrition, severe emotional distress, depression, anxiety, a decline in concentration, comprehension, judgment, fatigue, irritability, depression. Interestingly, also a preoccupation with food, body image, exercise, social withdrawal and isolation, low or decreased sex drive. These are very similar to what we see with anyone with a significant level of malnutrition, whether from body image, deliberate restriction, binging, purging, or other types of food or swallowing or choking phobias. And what we learned is that malnutrition to the brain causes a direct effect on cognition, emotion, and behavior, increases obsessiveness, increases rigidity, a great deal of body-related behaviors that we see. So eating disorder or eating behaviors, a whole long list of them. So eating with certain utensils, overheating or underheating foods, overuse of condiments, eating in a certain order, different times of day, a lot of rules that we see with restrictive eating in general. They also learned in this study that recovery is absolutely dependent on physical renourishment. So the group of there's kind of a third of these men were able to gain full refeeding and medical stabilization, as well as psychological stabilization, loss of these symptoms. Another third refed, but continued to experience the psychological effects of refeeding or of malnutrition. And then another third was actually unable to refeed and continue to have the physical and psychological symptoms. So see here, I skipped a slide. Let me make sure I'm on track. So treatments for eating disorders. So we know that they're serious, it's a big deal. We also know from research that the swiftest refeeding and weight restoration is associated with long-term positive outcomes. So it's actually necessary to start refeeding very swiftly, early in treatment. So there are several different, so there are two main evidence-based treatments for restrictive eating. The adults treatment that includes insight and motivation, self-driven insight and motivation, and that would be Chris Fairbairn's cognitive behavioral therapy for eating disorders. I'm not going to talk about that one today, but that's so useful. Both of these manuals are good, easy reads and describe specifically why interventions are required. The one I'm going to discuss today is the gold standard, which is Locke and Lagrange's family-based therapy for anorexia. A lot of work came from Maudsley Hospital in London, and so this is commonly referred to as the Maudsley method. There are also other associated treatments for eating disorders that include mindfulness, internal family systems, dialectical behavioral therapy, but because this piece with restrictive eating is entirely dependent on refeeding, those will come at stage 3 once refeeding is complete and we've been able to transition responsibility for food back to the adolescent as appropriate. So with family-based treatment, the interventions are, or the primary goals are refeeding, to work toward refeeding and normalization of eating behaviors. So that's always what we're aiming for. Often, so both of the treatments, CBTE and FBT, involve food tracking and in-session weights. In-session weights is kind of controversial. So we also know there's a great deal of distress with an OCD type disorder at refeeding and seeing the weight in the therapy session continue to increase when that is actually the biggest fear. So a lot of professionals and a lot of treatment programs in general have a blanket rule where they do not engage in weight exposure or weight knowledge at the beginning stage of treatment. And that is an issue topic intervention that's introduced when the therapist feels and has prepared the client for readiness. There's externalization of the eating disorder from the healthy self to help identify the thoughts and emotions, urges, and compulsions associated with the eating disorder. And there is a high level of tracking and accountability. So there's a lot of urges to compensate for eating more food during refeeding. And so that means a great deal of supervision and monitoring of what food is going in. Do we know that, do we need to increase the food amount because it's not the right amount, it's not enough, or because it would be enough, but they're not eating 100%, or they're eating 100%, but they're sneaking compensatory behaviors. So a lot of tracking and monitoring in this work. I have to note here, best practices in most all of our licenses across treatment include a multidisciplinary treatment team, including, like you all hear, physicians, psychiatrists, dietitians, therapists, as well as school and work environments or social supports, anyone who's going to be supervising meals, snacks, grandparents, and the like. The two evidence-based treatments I've referenced do not include anyone but a medical doctor and a therapist in the treatment, and instead recommend that the patient and their family or the parents figure out how much food on their own through trial and error, how much food is the right amount of food to eat. For teens, the recommended amount of gain is 1 to 2.5 pounds per week. So we are talking thousands of extra calories per day above and beyond what would be typically like a normal eating requirement. And these are patients who are eating significantly less already, and their body systems are not used to having this much food. They do feel sick, often vomit with refeeding. It's a very delicate balance. But the difference in treatment programs versus these protocols is that there is a significant amount of ownership taken by the parents who were putting in control to learn how much is the right amount and for weight gain, and how to do that when they've got a teen who's not on board. In treatment programs, we have dietitians who kind of come right in from the start, because remember, early refeeding is the best indicator of progress. So why not just kind of lay it out and say, here, this is about how much we're going to start here and see where we go. And there's a significant benefit to that as well, especially in medical systems. But, so those two differences that we see there. And we certainly very much appreciate the input of our dietitians, who are amazing. So family-based treatment. So what does this consist of? So the role of insight and motivation is so different with restrictive eating disorders. Clients themselves are not coming in and saying, I have a problem, I need help, please help me eat more and potentially gain weight. And because they have this spiral of malnutrition, they're further obsessed with body dysmorphia, food, exercise, all the rules. The funnel of what they're allowed to eat decreases over time, and they have all of these rules. And these are our previously people-pleasing, perfectionistic kids whom parents have not had to enforce this firm boundary and structure with. If there is insight with anorexia, there's very rarely a willingness to refeed. So we task the parents with taking control and refeeding their kiddos. They are the primary agents of change. So our treatment is entirely controlled with, or entirely aims to empower parents to take control and learn how much and how to effectively refeed their child. I don't actually have to, similar to MST, multisystemic therapy, I don't ever actually have to meet the youth, but if I can help the parents learn how to feed, how much is the right amount, work with their doctor, do their own weighing at home, we can be just as effective. However, there are normally other types of emotional distress associated or that help help kind of trigger or drivers to restrictive eating that we want to be able to manage in treatment. We want to do a lot of cognitive work as we move through treatment. So of course we want the teen involved, but it's important to note the priority on supporting parents in this treatment. And it's a lot of work. This is often incredibly overwhelming for parents. So they need to have complete control of food preparation, plating, do this confidently, encourage the eating and implementation of all meals and snacks that occur throughout the day, plus supervising for 30 minutes after eating to avoid compensation. So often parents are using FMLA from work. They're relying on extended family for support. Sometimes we keep kids out of school to appropriately monitor and supervise depending on level of severity, or we're working with the school for supervision during meal times. And that includes counselors taking pictures of food back and forth to parents, like, here's what the lunch is before I put it in the bag, send me the picture of what they pulled out of the bag or what they ate. So we do 504s and IEPs with kids, and FMLA for parents when that's required. Parents have to link reinforcements for eating with consequences. And I like to explain this through the idea of, like, if you're sick on Friday, you can't go to the dance on Saturday. Likewise, if you don't eat what's required of you, you need to be in a day, you need to be on bed rest and not have access to activities, cell phones, motivations. So we're using behaviorism here to try to shape the behavior toward refeeding with the loss of those reinforcements as consequences when it doesn't occur. So when a meal isn't eaten at 100%, we encourage a supplement like an Ensure, or can't think of the other one. the supplements that are 250, 350 calories. And so you have a certain length of time to eat your food. If that's not done, now you have 10 minutes to drink the supplement. And you basically stop everything. You sit at the table with your teen. You have to be calm and collected and supportive, even, amidst this frustration, and get on track toward refeeding. You're managing behaviors like anger, aggression, lashing out, threats, or behaviors of self-harm, or suicide attempts, a lot of anger wave, the emotional wave. It's really, really difficult for parents. And you can see the behavior of them play out. There's also an emotional and logical component where they are trying to, they try to negotiate what they can eat or make exchanges, or I don't want to eat that. I'll eat this instead. What if I agree to eat this? And the parents really need to take control at the stage of refeeding where the child has so many conflicting thoughts and unhealthy thoughts about food and needs that they shouldn't be able to negotiate or make those decisions. And this is very hard, and it feels harmful to the adolescent. From treatment providers that are new, feel like this is overly harsh. Is this really necessary? This is a good kid. And from parents, that feels to them like they are causing distress, emotional distress. And if they can ease that distress by negotiating a bit with the teen, why wouldn't you do that, right? But that's the eating disorder getting control and manipulating the situation. So of course we recommend against that. That's a loophole that interferes with recovery. So this is a lot of intense work at home. Parents also have to oversee sports and activity. Medically unstable clients are encouraged to stop all physical activity until they are medically stable. And at that point, we have to regulate and monitor it so that they don't over-exercise or compensate, but also because if we're struggling, it's very hard, a lot of food to gain a pound or two a week. And when we add physical activity in, that means a recovery snack. And that makes it even more difficult for parents and kids. And so now that's more food. But physical activities, sports and activities tend to be a huge motivator to get teens on the bandwagon. And then this is highly taxing on siblings, the family system, resources, finances, family stress, taxing on a marriage. It's very, very difficult. A lot of impacts. I won't talk a lot about the emotional wave, but I find it similar to the tantrums that toddlers have, where you get past a certain point and you can't ration reason with them, help calm them down. You just need to take a step back, let them ride the wave, and then come in and help support and make sure you're still working toward goals. You can try to minimize the size of the wave or that emotional lashing out, but learning that they're going to come, to predict them, to identify them ahead of time, and ride the wave, surf the wave, and learning to help your teen do that as well is really, really useful. So let's see here. A lot of reasons that we struggle to refeed. When teens are restricting significantly, they become hypermetabolic. So while they might at first begin eating a much larger amount of food than they did previously, they continue to lose weight, which does that make sense at all? But their system is really just hyperactive, and they need to kind of get to the point where things level out and their body responds at the same level. This is really difficult because at the beginning of refeeding, there's something called delayed gastric emptying. So imagine hibernation mode of the body, things shut down, heart rate, reproductive, all of that. And suddenly now you're trying to force a bunch of food down to a system that's actually been kind of on strike. It's very uncomfortable. It takes a while for the GI tract to start emptying like normal again. And that's painful. It's necessary. But it's difficult. So the kiddos are also having a great deal of anxiety, distress, anger, fear of weight gain, and it's actually happening. That's their worst fear. So there's often a continual fight back while this is happening. There's a lot of rules, trying not to eat 100%, saving the last bite. That's kind of an eating disorder win, to not eat the last bite on the plate. And then there's manipulative behaviors, lying about food, a lot of claiming I'm sick, I'm full, I'm ill, hiding food, throwing away food. I think we found a chicken bone in a boot once, and a pork chop in a hoodie. Is the best way to kind of manage your need, that compulsion to avoid food but make your parents happy by thinking you did, is to hide or throw away food. That's extremely common. There's also the compensatory behaviors. Sometimes we'll notice kids take the longest route around a room just to get any extra steps in that they can, or private time in the bathroom, might be doing push-ups or other exercise, waking up in the middle of the night. On top of all of this, a lot of common backslides include restarting school, travel away from your normal environment and the foods you're used to eating, inflating, eating out at restaurants, sports seasons, starting or getting permission to go back to sports, because that can trigger that obsessionality and compensatory urge, right? A lot of our clients will have, they'll exercise way after like a 2-hour sport practice, right? Or they'll feel guilty, that's not enough, or I didn't get enough out. Also, illness is so we make a lot of, it's a staggered recovery. We make a lot of progress, and then someone gets sick and loses. And these kiddos can lose weight like you wouldn't believe, like have the flu, 11 pounds down, that we fought tooth and nail for 4 months to get those 11 pounds. So, there's a lot of barriers. We start to give, when we have indicators of recovery, we start to give some of that responsibility for some meals and snacks, with a lot of oversight back to the adolescent, with continuing refeeding or weighing. And oftentimes that's not successful. The eating disorder, we've taken away control. And once we start to give that control back, oftentimes eating disorders are empowered to take the driver's seat. Let's see. I'm on the wrong slide. So sorry to flip around here. So these are the 2 books that I recommend to parents, because often parents, this is a whole new type of parenting. There's a lot of stigma about restrictive eating, about anorexia and eating disorders in general as being attention seeking. They don't receive a lot of support often from friends or family, or it's uneducated attempts to be supportive, to try to force feed food, or we like to joke, tell people like, just eat, like, oh, who didn't think of that? And these 2 books are amazing. Maria Gansey's Survive FBT is a very short, quick, thin guide for parents about what you're about to go through, what to expect. And Eva Musby's work is amazing. She is a parent who had it with a child with an eating disorder, and she interviews, and she's obviously a writer, and she interviews other parents, and with a lot of really great quotes and examples from parents, well-placed, understanding what the process looked like. And this is written specifically to be used as needed. Read chapter 1 and then flip to whatever chapter you need support from at this point in your child's recovery. So these are amazing. I've been very impressed with the great support. Often we don't have adolescent support groups and outpatient treatment because there's too much triggering of eating. So when we're an outpatient, we like to keep things within the family and not expose our teen to another kiddo's weight gain. It's easy to feel, there's already the body dysmorphia, and then to feel very easy to feel overweight when you're in a group with other young people who are underweight. But we do have parent support groups because it is so necessary for them, for our progress and recovery. And they often don't have others in their lives who are aware of this type of treatment and what it entails. So a lot of systems in action here, including, of course, the adolescent, a lot of family therapy. SBT's one of the first meetings is a family session with the entire family, where we ask siblings to share how the eating disorder has affected them and how they feel about it and their concerns and worries. And this is always a very powerful session, so powerful. And it helps the therapist get to see who else is in the family that you're not going to be working with, and how they can be supportive. We also do not put siblings in the role of the monitor or supervisor. They are cheerleaders for their sibling. That's really how we'd like them to show up. We involve extended family members, anyone who is trusted with the knowledge or any kind of involvement in conversations about the eating disorder. Parent support group. Of course, there's often a PCP, there's a medical specialist in eating disorders often involved, dietitian, psychiatrist, coaches, sporting coaches. They have to be on board with, if the kiddo doesn't eat that day, they don't get to go to practice. And that might mean they don't get to go to play or participate in a meet or game or match if they haven't eaten that day. And that consequence really is on the shoulders of the kiddo and their eating disorder. And most coaches are on board. I actually haven't come up against one who's really not okay with that situation. And they're normally very supportive. Schools, if we need to take time off, have half days. And then of course, if for whatever reason, the intensity of the eating disorder or the medical symptoms or medical instability or family resources or lack of a caregiver who has resources to provide all of this, then we're really looking at higher levels of care like IOP, partial programs, inpatient if needed, and residential. And that includes, we love our social workers for helping us manage insurance networks who are normally, and they're not a lot of higher level of care systems that take all insurance is really difficult. And it's amazing to have those resources and someone to help connect us. So the few programs that we have in Ohio for teens, sorry, it's flipping through too quickly. So for adults, we have the Emily program in Columbus as well, ERC in Cincinnati, kind of Northeast Ohio. We're really looking at Akron children's eating disorder. I know someone said you're in Cincinnati. I'm not sure about a program at Cincinnati Children's, but I do know that Nationwide Children's in Columbus has medical care, outpatient, IOP, and partial. And let's see, there is a residential care in Columbus now. There aren't many. This might be the only residential care for adolescents in Ohio. So when we're pursuing residential, as many of you know, we're really looking out of state and trying to get insurance approval or single case agreements with Medicaid to cover out of state higher level care. All right, now I'm done talking and can open up for any questions you all